Oh, Dr. Bremner.
Are they going to be able to see my mouse or no? To point
They
this.
should, I think they should
Okay.
be able to see it, yes.
This is not mine.
Oh, I'm sorry. I'm so sorry. This one is yours.
That's okay.
All right.
Okay, hi there. I don't know exactly what you guys can see. I can only see one person. It's some lady in a bathrobe. So no, I can't see anybody, but I assume you can see me or part of my face or whatever. Thanks for listening in. We've got an hour or a little bit less, and I'm sure we'll have time to get through my slides and ask questions. You can ask them during the talk or afterwards. If you ask them during the talk, then we'll be reviewing those and hopefully we can answer some of those during the talk. I wanted to talk about just a basic background of shoulder replacement and reverse shoulder replacement, which is becoming much more common nowadays. And then also why we pick one versus another and the different facets of rotator cuff repair or rotator cuff pathology that might preclude one choice or make one more favorable. I have some disclosures for companies that I work with to develop research and things like that, but nothing that is pertinent to today's talk. Dr. Honkamp also loaned me a few of his slides. He's one of my partners. We have 3 centers here, and I think we have about 25 orthopedic surgeons and 2 physiatrists that do all sorts of pain medicine and PRP and things like that. And we have a couple podiatrists on staff too. And we're getting our spine center going as well. So I'm sure a lot of you have had a chance to work with us. We appreciate your patronage. First of all, just kind of in general, this talk does not have the scope of evaluating everything regarding to shoulder pain and dysfunction, but some of the things we evaluate, shoulder instability, especially from sports injuries, they can oftentimes cause arthritis in the shoulder. So, we want to check for anterior inferior instability, things like that when we see a patient with shoulder pain. Rotator cuff injury, which we'll talk about a little bit more later on. It's very common. If you see anybody over the age of 60, you're going to see quite a bit of rotator cuff dysfunction. I tell my patients who are over the age of 80 that about half of the people over the age of 80 have a rotator cuff tear, and they may or may not know about it. It doesn't mean it needs to be treated, but it's just that's how prevalent it is. And then really commonly, of course, bursitis and rotator cuff tendonitis, which we see all the time. You guys see it all the time, and that really responds well to physical therapy, sometimes injections, anti-inflammatories, and most of the people will get better without surgery with the bursitis and tendonitis, but it's hard to kind of figure out some of these things in examination. One entity that can really act a lot like arthritis is a frozen shoulder, and so that's one pathology that has quite a bit of overlap on physical exam, but very stiff, active, and passive range of motion, very, very painful, probably more painful than arthritis, especially in the acute phase. And but relatively younger typically, and also the x-rays would be normal in a frozen shoulder typically. MRI can be helpful with that too, but it's not really a modality that we need to get a lot of. It's usually based on x-rays and clinical exam, and that can be treated with physical therapy, anti-inflammatories, cortisone injections, and it's a self-limited problem that will resolve. It is more common, just a note, it's more common in diabetics and people with low thyroid hormone, and those people it's harder to treat too, and sometimes those people will need a manipulation or a shoulder scope or something, which I favor manipulation. Rotator cuff tear, there's so many different kinds of these that we're not going to go into that in this talk, except as it relates to shoulder replacement and reverse shoulder replacement, and osteoarthritis, which we're going to be talking about more, which is wear and tear of the joint, of course. The different options for mechanical replacements, typically total shoulder replacement, where there's a ball of some kind and then a socket, and they're in anatomically where the old ball and socket were. A partial replacement isn't used that much anymore. In a younger person, if they have a really good socket, but the ball has some pits or something in it, you can maybe do a partial replacement or a resurfacing. This pictured implant is actually one that we used to use for people with a worn out shoulder and a rotator cuff tear. So it's called a rotator cuff arthropathy. So partial replacements have been somewhat supplanted by reverse shoulder replacement, which we'll talk about a lot. And you know, a resurfacing, which I don't do a lot of, but maybe for a very ultra young person, like a 30 or 40-year-old, if they just had a defect in the humeral head, you might do something like this. Then we're going to be talking about this as well, reverse shoulder replacement. And it's similar to a metal and plastic ball and socket joint, but the ball and the socket are reversed. Did you say that they can see my mouse? Oh, you think?
I think
Okay,
so.
I'm going to try to use my mouse sometimes to point to things, but now the ball is on the socket side and the socket is on the ball side. So that's why it's called a reverse shoulder replacement. And when I was in residency, which is back in like 02 to 07, those were just starting to come out and be successful. So we've got, you know, probably about 20 years of really good research on that. And it's been an important part of our armamentarium lately now. This is just a schematic of a reverse and a regular total shoulder replacement. Also, the total shoulders are also called in the literature anatomic shoulder replacement, you know, compared to reverse shoulder replacement. So they're both really called totals, but you can hear them talked about as that. Well, you guys know why we do this. If we've tried everything and it's failed, then this might help people have increased range of motion, less pain, and doing more activities of daily living without pain. These patients do need to be committed to quite a bit of physical therapy and protective time after surgery to have a successful outcome. I usually tell people about 6 weeks in a sling, and I'm hoping they wear it at least 4 weeks then, but 6 weeks would be fine too. I don't think that getting a person out of a sling at 2 weeks or anything like that increases the success rates, and it will increase your tear rate for subscapularis and things like that, which we'll talk about more, is very important. And like we talked about, physical therapy is very important. The shoulder, you know, it's a ball and socket joint like the hip, but it's much more mobile. And whereas the hip is highly constrained, and the ball and the socket are really surrounded, the shoulder is a pretty flat articular surface on the glenoid and a round ball, and it's very unstable if you don't have the rotator cuff and if you don't have a good labrum surrounding it. So that's why we can do so many things with the shoulder, but you have so many more injuries to it than typically, say, the hip. This is a simplistic thing, but it's just like wearing a tire for arthritis. And some reasons why it might wear out are genetics, you know. So, you know, some people are just programmed to have that wear out at a younger age. I certainly see a lot of injuries or trauma that cause arthritis, especially things like posterior shoulder dislocations, anterior shoulder dislocations, repeated shoulder dislocations. Traumas can be a factor with that too. Of course, a little bit less common, but and then some things have to do with body weight and just how you use the shoulder to it, that it can wear out faster. Similar to a lot of shoulder problems, these patients have a dull ache in the shoulder. A lot of times they come early on and it's pretty mild ache, but you know, pain where this guy's grabbing or pain down the arm to the elbow, it's certainly not exclusive to shoulder arthritis, but that is what they have. And stiffness is another thing that they don't really, maybe it's kind of insidious how it happens. Sorry, I thought I do have my phone off, but it's vibrating and bothering me. But so sorry. So stiffness, again, like we talked about, differentiate that from frozen shoulder. And you do that by getting x-rays in addition to the physical exam. And sometimes, I mean, I don't go by crunching or grinding in the shoulder, but because almost every pathology, even without pathology, people say my shoulder always pops, and it may or may not be important. But the stiffness and the pain and x-ray findings of arthritis is what we see with arthritis. In the clinic visit, we will get a series of x-rays, usually an AP like this, where we can see the joint space well. It's got to be angled a little bit. We also get a scapular Y, which is coming from the side, and we can see if there's any instability, and we can also see what kind of acromion they have. So sometimes a big hooked acromion can cause a rotator cuff tear. And on this, you can see that the ball is centered on the glenoid. So I like to see that this line up along the bottom of the scapula lines up pretty well with the line, and it just should go right into the line of the humerus. So that's like, it's like Shenton's line of the hip. I call it Shenton's line of the humerus. So we don't want to see the ball up higher, and we don't want to see the bones touching. So here's a typical arthritic shoulder where the joint space is narrowed down, some bone spurs up above on the humeral head, some bone spurs down here. And this is called a goat's beard deformity, but it's just a big inferior osteophyte, and that will interfere with motion. So that part of doing a shoulder replacement is to get rid of that bump there. You can have arthritis at the AC joint as well up here, which really isn't that important. You can have pathology from that, but not what we're talking about today. You guys all know the typical treatment for this. I do some gentle PT, but when you know it's worn out, I certainly don't try to increase a lot of range of motion. You guys all know that, but a lot of times that'll just cause a lot of pain. So I tell people that some gentle therapy will help with pain. It can help with strengthening, but they're probably not going to achieve much more motion with PT when they have a really worn out shoulder. We do cortisone injections into the joint. You can do that ultrasound guided or without ultrasound. Without ultrasound, it's a lot like just where we put our portal in for doing shoulder scopes. So if you do a lot of those, it's not, you don't have to have an ultrasound machine or an x-ray machine. I don't really recommend glucosamine chondroitin. I don't think that a lot of studies show that it helps a lot. The Synvisc type things are the gel injections that we use in knees quite a bit, which they're not new things, but they're advertised heavily now in the newspapers here in Des Moines by some clinics. So the hyaluronic acid really doesn't have any role in the shoulder at this time. It's not covered by insurance, and not a lot of evidence that shows that it works. And then we have a stem cell program at our place, but I don't think that it's indicated for arthritis of the shoulder. Tendonitis, and if somebody's got some
yeah, I'm just back in
disposable income that they want to use on for stem cells for tendonitis, I think it's reasonable to try that for, like a partial thickness rotator cuff tear, but it hasn't been shown to reverse arthritis or help enough to warrant the expense for that. So we see somebody with arthritis in the shoulder, and they failed all this non-operative treatment, and they are willing to undergo the risks of surgery, and they're willing to do the rehab that they need to do, and they're cognitively there and ready for what it's going to take. Then they might be a candidate for shoulder replacement. Some people that aren't a candidate for shoulder replacement, in my opinion, and it's the same for knee and hip replacement. Not everybody, it's not a strict cutoff, but in general, a BMI of over 40, we would want them to work on that. Hemoglobin A1C of greater than 7.5, they wouldn't be a candidate for a shoulder replacement from diabetes. And smoking, they would have to quit smoking at least a month before surgery to be a candidate for any kind of joint replacement in our practice. So the basic idea of a shoulder replacement, we'll talk about that. Here's again an x-ray of a worn out shoulder with a goat's beard osteophyte down below and no joint space left. And we put in a new plastic socket. You can see on the glenoid side, typically if they have a central peg, there will be a metal piece in there, so you can see where that is, and you can watch year to year to make sure that there's no loosening of the component. And then there's always some form of ball on the humeral side, and then there may or may not be a stem. So this is an anatomic total shoulder. This is showing up close, the polyethylene liner or the plastic liner for the socket side. This one has 3 peripheral pegs that typically have a little bit of cement on them. It's not as much cement as you use like in a knee replacement, but just to do a little bit of cement for those 3 holes. And then the central peg, there's some room for bone graft around that, and it does rely on bone growth to go into there and get into those glutes on the central peg. They're not all like this. Some have what's called a keel, which would look more like the bottom of a boat, but most of the ones and all the ones that I use have pegs of some kind. Again, there's a shoulder replacement. It's got a highly polished metal alloy head, plastic socket, and it may or may not have a stem. The incision for this, we usually do some type of kind of a beach chair position. In this patient, the head is up on the upper right side of the picture. That circle is the coracoid process. We go down from the coracoid process down towards the junction of the medial third and middle third of the upper arm. We use the deltopectoral interval, which is the interval between the deltoid and the pectoralis major, and the cephalic vein is usually in there. It's always in there, and we protect the cephalic vein during the procedure. Once we get the those two big muscles pulled apart, then we're looking at the subscapularis, which is a very important part of the case. So to get to the shoulder joint, typically you have to release the subscapularis either off of the bone or in the mid part of the tendon, or some people actually take a chunk of the bone that the subscapularis is attached to and reflect that back so you can do your work. And then the important part is getting that to heal afterwards. And that's why we're so careful with the subscapularis management afterwards. We typically do general anesthetic and a nerve block, interscaling nerve block, which helps a lot with pain for about 12 to 18 hours typically. And these are a lot of times being done as same-day surgeries, or in some older people or with comorbidities, we might do overnight. The patients need supervision to protect the subscapularis, and that may that's reflected also by how we don't do a whole lot of physical therapy the first month, because we don't want patients doing a lot on their own at home the first month and wrecking the subscapularis, because if they do, then you get an unstable shoulder replacement and it has to be changed to a reverse shoulder replacement. So similar to like a Bankart repair, like an open Bankart repair, we have to protect the subscapularis. And this is kind of a typical, you guys know a lot more than I do about this and have your own protocols, but typically for about 4 weeks of sling, sometimes 6 weeks, and hand, wrist, and elbow motion, working on getting some of that edema pumped out of the arm, and doing some gentle Codman exercises or pendulums. If I have somebody, a therapist, OT or PT, or if family seems like they're with it enough, I'll teach them to elevate the arm to 90 with the arm at about neutral, and then also externally rotate to 0, but that's about all we want to do. If somebody's just doing their own stuff at home, I won't do isometrics, but if they're seeing a therapist, we can work on some isometrics. And then later on, we'll work on getting the passive elevation better and starting some active motion, and some real gentle strengthening can start at 8 weeks. But it'll be about 3 months before I'm really comfortable with the muscle strength being ready for strengthening. So these people, they really should be older people. The most satisfied patients are going to be ones, you know, who are 65 and up and want to do golf and fishing and mess around in their house and do their yard work and stuff. If you're a laborer and you're swinging a sledgehammer or digging dirt all day long, you are not going to be happy with the shoulder replacement, and it's probably going to wear out fast too. So we really don't want to do a lot of impact and things like that on a shoulder replacement. But people will get reliable, decrease in their pain, and improve motion most of the time. Again, we want to limit some of the impact stuff, so limit overhead lifting, avoid impact like swinging a heavy hammer at work, that sort of stuff. There are some other options for young laborers, but not a lot of great options for young laborers with this. If you did have to do a replacement and you could get away with a partial shoulder replacement on the humeral side, if the socket was pretty pristine, you could try that, but it's not going to do that great and they're not going to be that happy with it. So hopefully they're older, but there are a lot of people. I mean, one of my partners was asking around about a good option for an 18-year-old who had a terrible shoulder, just totally crashed. So there's not a lot of great options for that. They have a great survivorship early on, 10 and 15 years. Those are on the left side. There's some factors that might cause these to fail earlier. And then the main ways that they fail, the number one way is glenoid loosening. So the socket kind of rocking and coming loose is one thing that we've been working on a lot. Infection, and typically that would be kind of a low-grade infection. It could be a raging infection from staph or strep, but a lot of times you don't even know that they have an infection just from pain or loosening. And the bacteria that can cause that a lot is Propionibacterium acnes or P. acnes, which is pretty common in the groin and armpit. And so we do a lot of things to prevent that infection. But that is something that can cause long-term or short-term failure. And then instability isn't that common, but the ball coming out of the socket could happen too. One thing that will happen is if you do try to do a regular shoulder replacement in a patient who does not have a good rotator cuff, then they will get what's called the rocking horse phenomenon. So we have to have the rotator cuff, as you know, four muscles and tendons that surround the humeral head and pull it into the socket and stabilize it on the socket. So if we have an uncoupling of the force couple and maybe the top muscle's not working right, the supraspinatus or the subscapularis up front isn't working right, you'll get front to back motion or up and down motion, and over time that will cycle and make the socket loosen. So when we used to try to do a shoulder replacement for somebody with a bad rotator cuff, they would fail early on, and that's one of the reasons why reverse shoulder replacements were developed. As we talked about, there's the labrum around the socket that helps with stability, but also the rotator cuff is supremely important for shoulder stability and the four tendons of the rotator cuff. I'm going to show you some pictures of a torn, neglected rotator cuff tear. And so sometimes the supraspinatus and these other rotator cuff tendons can be fixed, and that's ideally what we want to do. Also, sometimes you'll have a rotator cuff tear, a small one, with arthritis, and you can do a regular shoulder replacement and fix the rotator cuff if you think it's going to heal. But sometimes these cuff tears are not fixable, and I'll kind of talk to you about what we look at to decide if they're not fixable. If they're not fixable, as I said, you should think about a reverse shoulder replacement if that's indicated. This is a patient of mine. On the left picture, the small arrow is where the rotator cuff used to be attached on the greater tuberosity, and the supraspinatus has retracted all the way back to the level of the glenoid here where the big arrow is. So this tendon used to be attached where the small tendon is. You can see how close the humeral head is to the acromion process now. And you can see down here is the bottom of the socket, that this part of the ball used to be down here at the bottom of the socket. And so everything's moved upward, and it's actually what'll happen is it'll start to wear a socket into the acromion process up here, which it almost makes another socket. We call it acetabularization of the acromion process. And when you see this upward motion, it's a lot of times not a fixable rotator cuff tear. So if this space on an x-ray is less than 4 millimeters or so, you won't be able to fix that rotator cuff, most people think. There's some other options, just as an aside. There is something new that I haven't done where they put a balloon in there to try and just kind of make a spacer and a fulcrum so that you fill this balloon up, and then hopefully that will allow you to lift up your arm without pain. You can do a superior capsular reconstruction, which is using like a graft of tissue and putting it in there where the rotator cuff used to be, and that can help with pain and maybe a little bit with function, and it can help to connect the front rotator cuff muscles to the back ones and kind of improve that force couple again. On the right picture, so this front picture is a coronal or a frontal picture of a right shoulder. The right picture is that same shoulder, but it's at a sagittal image, which is like a cross section. We're looking at, well, I like to think of this as like the T-bone steak here. So this is the scapula. You guys can see my cursor, right? On there, okay. So the scapula is the T-bone here, and up top is the supraspinatus, and this is in the supraspinatus fossa, and you've got the subscapularis and the infraspinatus and teres minor down here, and these should all be dark muscle. So this is dark on the MRI. The fat is light, and so what we see here is that the supraspinatus, all three muscles really have turned to fat, and that's what we call atrophy. And when you see this is what I'm looking at when I get an MRI with somebody, even if I know they've got a rotator cuff tear and I want to find out how old is the rotator cuff tear. Is it so bad that there's atrophy now in the shoulder? Because this is not a fixable shoulder, even if you just showed me this one picture of the supraspinatus, because if there's more than 50% atrophy in this space, so more than 50% is white compared to dark, then it probably is not going to be a successful repair. And this is like really bad. So. And that just happens with disuse usually. So you tear it and now it's not attached to anything. So over 5 or 10 years, when this person neglected it, it just turns to mush. This is showing the superior migration that we see when the cuff is torn. The pull of the deltoid pulls that upwards. And right here, we're seeing that the humerus is resting on the acromion, where there should be a space in between where the rotator cuff is. And then we also do see a lot of times in cuff tear arthropathy that there's more superior wear on the socket compared to regular arthritis where there's more posterior wear typically. This is just showing a schematic here. You can see the space here between the acromion process and the greater tuberosity. It should be pretty big. If you see on an x-ray that the humeral head, which is about right there, is resting up near there, then you think long-standing rotator cuff tear or massive rotator cuff tear. And this is the subscapularis that we're talking about quite a bit. So I typically will cut through the tendon here to get to the shoulder for a shoulder replacement, and then we're done. We need to sew that back either through transosseous tunnels going through the bone, or anchors, or you can just use sutures. Some people actually cut the bone here because bone heals pretty quickly, and they'll cut the bone that's attached to the subscapularis and peel that back, and then when they're done, they'll wire or repair that bone down to the bony bed that they took it off of. But whatever you do, that's got to be successful, and it's got to be protected after an anatomic shoulder replacement. This is kind of showing that the deltoid, when the ball goes upwards, that tension that you need for a muscle to work goes off and you can't lift up the arm. It's one of the problems. So when your rotator cuff's gone and you're asking your deltoid to lift it up, there's no stability to the fulcrum down at the ball and socket joint. So when the ball goes up, the deltoid gets limp and the arm can't lift up. And you can get what's called pseudo paralysis. So you'll see those patients where they can just lift it up to 30 degrees and they really hunch up their shoulder and move their whole body over to try and make it happen. This is showing a good joint space here. It's not exactly a glenoid view, but it's showing a good joint space and a good space between the acromion and humeral head. And this is showing some narrowing of the joint space. Again, it's not perfect straight on, but inferior osteophytes, inferior osteophyte or bone spur, and we're resting, the humeral surface is resting on the acromion process. So we know it's a long-standing rotator cuff tear and arthritis. Reverse shoulder replacements are getting much more common now, even for those without a rotator cuff tear. They used to be kind of last ditch scenario, and you kind of cross your fingers and hope for the best. And like in 2002, 2003, we were kind of poo-pooing them because they had about a 30% complication rate, whether it's dislocation or loosening or infection or hematoma. But now they're on par with a regular shoulder replacement, and they're very helpful. The last few years, about a third of reverse shoulder replacements were done even in patients with a normal rotator cuff. So they're getting more indications. In my hands, I would use it if I was worried about the rotator cuff at all. If it was very thin, wispy, partial thickness rotator cuff tear in an older person, especially in an older person, I think it's a better option. So if you have a very old person, it might be a great option. If they have a lot of damage to the socket, the reverses can really rebuild the socket better. So you can have augments and a lot of screws on that side compared to the plastic. So if they have a lot of destruction of the socket, a reverse is good. Or if they really have terrible range of motion before surgery, just awful, then a reverse might have better results than an anatomic shoulder replacement. And then, of course, if they are missing the rotator cuff, then it's really the only shoulder replacement option. This is schematic of what we do. So again, there's a glenosphere on here, and underneath there is something called a metaglean. And the metaglean has a porous surface, so it can grow to the bone, and you can put in anywhere from central peg, and usually 4 screws are available. And so you can, if you have a problem with the glenoid being totally screwed up, you can rely on this better than a plastic piece that just kind of fits on there. So that's why this might be better for people with severe destructive erosion of the glenoid. And then on this side, there's a stem usually down the humerus and a plastic cupped plastic disc that goes onto this. And it stretches out, that deltoid that was loose in that last picture. It puts the deltoid on tension and allows the deltoid to be a more strong elevator of the arm. This is one of my patients, I believe, and it's just showing a reverse shoulder replacement. You can see here's the acromion process, and here's the greater tuberosity, and it really does push that away and gets the deltoid on tension. One of the complications can be if you put it on too much tension, you can get an acromion process fracture. And so some people might come in, they might be doing great with therapy, and you might see them and they're doing amazing, and then the next week they start having pain and they can't lift up their arm. And that would be something where you'd want to refer them back to the surgeon, check an x-ray, make sure that they didn't fracture their acromion. So that is a complication that we try to minimize. There's also can be some cosmetic defect here. You can imagine if you stretch that arm, you're going to make that arm a couple centimeters longer, and you can get a little dip in some designs just off the acromion process. So it can look a little funny, and some people, I try to tell people that will happen in a lot of people, you know, if they're thin. So the rehab's similar, but I don't worry as much about the subscap protection because a lot of times I don't even repair it. We'll talk about that a little bit more, but the subscapularis, you can, if you recall, we're moving that ball away from the socket. We're putting the delta on more tension, and a lot of times you can't get the subscapularis back to where it came from unless you really want to constrain the arm down. So a lot of times I don't repair the subscapularis, and then I rely on the intrinsic stability of that reverse ball and socket, and we don't have to worry as much about the subscapularis. But I would caution you, you know, not every surgeon thinks that way, and not every one of my cases do I not repair it. So go by whatever the prescription is, please. Expectations for this, I talk to my patients about less grinding in the shoulder, less popping, less pain, of course. Hopefully, it just popped out like off the full screen. I don't know. Do you guys see that? Maybe I.
Like the PowerPoint. Hold on just a minute. We'll get the PowerPoint back up. I'm not sure what happened. Yeah, the PowerPoint is totally gone, isn't it?
Let's just reopen and I can find it if you know where it is.
Yeah, I can get it. It's right in my Teams here.
You want to sit down?
No, it's okay. Sorry about that.
Okay.
Not sure what's going on. Sometimes technology just kind of has a mind of its own.
Are you guys getting some questions yet or not?
I haven't seen any come in. This would be a great time.
Come on,
Anybody
people.
else? Yeah, bring on the questions.
Type up your questions. I'm 95% of the way done with my talk, so.
Hopefully you remember what slide you were on here.
Yeah.
And then, okay.
Any questions yet?
No questions. You must be doing a great job.
Yeah.
Well, this is one of those times when, until this opens up, there are no stupid questions. But once it opens up, then there can be stupid questions again. So go ahead and ask a stupid question if you could.
Hey, Dr. Bremner, thank you
It'll
so much.
load
for
it,
the
yeah.
Do you know how to?
I have a patient who wants to
get
bow
out of
hunt
here if
after
you
the reverse
want to
total.
load it, but if you
would
go
you
to view.
Okay, and the
you can-
slideshow?
And then,
Slideshow?
yeah,
All right.
yeah, and maybe do from current slide once the slide.
All right.
pops up.
Let me, are you guys seeing anything here? You all right?
Can you guys see the screen?
Yes.
Yeah, they're saying yes
Okay, here, let me go to view slideshow.
from current slide.
We come around and we can, I
Yeah.
think we can get started if we
Uh,
get going from that slide.
Slideshow.
To view, my bad.
Oh,
First
so-
slide, there you go.
current slide.
All right, are you guys seeing everything now? You guys? Okay, all right, thanks for your patience. So I tell people increased motion with a reverse shoulder replacement, decreased pain. I do alert them to the fact that they will have a possible cosmetic defect on the side of their shoulder that will look funny, a little divot. And also external rotation is not great with this. So if they're really relying on external rotation for something, I'll typically tell them they'll probably get to 0 degrees, which they're typically satisfied with. But this is not a great surgery to get external rotation motion unless you add a tendon transfer to it, which is quite a big deal, and a lot of morbidity with that, and a lot of people aren't doing that. I do have, if you have a patient with a reverse, I tell them to avoid extension of the shoulder and internal rotation, like when they're pushing up for dislocation. And that's for the first 6 weeks or so. And just I have them be careful on that. But this is kind of the mechanism where you dislocate your shoulder for a reverse. This is a woman at 3 months after an anatomic shoulder replacement, so a regular shoulder replacement. And I will try and click on her picture. There we go. Okay, lift them all the way up. And so we got good elevation on there, good forward elevation at 3 months. And not everybody's like that for sure. But she was, I had these two people come in at the same time. One was a reverse and one was a regular. And so I wanted to get this picture for this talk. So probably 165 or so of elevation. And then we have her go into this position to check external rotation, and she's really great. And her subscapularis is good. So you worry about that sometimes with external rotation, it's great, but she's 70 degrees of external. And she's really trying hard. And I think she's giving me the middle finger there, but she is really actually happy. She's very happy about this. But so that's very good motion for a total shoulder. So I don't guarantee everybody that. This is a lady, you can see the left picture, bone on bone, inferior osteophyte. And for this one, you could certainly get tricked into thinking this is just regular osteoarthritis. And I don't get an MRI on everybody, but on physical exam, she was very weak also. So typically, if you have central wear like this, you'll have a good rotator cuff, but I was worried about her weakness. So we got an MRI and it shows the superior subluxation of the humerus. So here's the bottom of the socket. And here's the bottom of the head. So everything's moved upward. It's touching the acromion process up here. This is a cross-sectional view again, showing that the scapula here and the supraspinatus up here is just trashed. It's all fat basically. So we know we're gonna have to do a reverse shoulder replacement, not a regular total shoulder replacement. This is her, and just a technical thing, we do want the bottom of the ball to be off of the glenoid like this. So we don't want it even with the glenoid, we want it below, because otherwise this piece, when it comes around, can bang into that and cause what we call scapular notching. So we want to have that low, and you also want to have it pointed like this, straight out, and not pointed upward, which you can be fooled into pointing it upward sometimes, and you can have dislocations then. So this lady is 3 months out from a reverse shoulder replacement, and she's got a little better than normal elevation for a reverse, but pretty typical external rotation and pretty typical internal rotation for 3 months. I think she'll still get better internal rotation than she's got here, but she's probably not going to get any better external rotation. So we'll look at that next year. Keep her elbow in and try and roll. So, maybe she's stretching it hard to 20 or so, but most people, I think 0 to 10 degrees of external rotation is probably what they're going to get. And I bet she'll get to, she's had her about to there. Okay. SI joint maybe there. So she'll probably get to L5, but on, like we talked, I've really beat a dead horse here maybe, but on anatomic total shoulder replacement, subscapularis management is integral. It's the largest and strongest cuff muscle, and it has several different jobs that it does. But I tell people, do not be pulling on a doorknob right after surgery. Don't let somebody resist you and pull inward, like what the pec or the subscap might work on. And what we found in the studies, although it makes sense to repair it, sometimes there's no clear benefit for a repair of this in a reverse shoulder replacement. And then in the future, for reverse and total shoulder arthroplasty, and actually it's now, but it's not future, but it's a development, is that we use CT scans now, especially on complicated bone loss studies, and we can find out where the bone loss is. There are special implants that we can order that have different augments so that we can replace bone with metal, or you can do a bone graft too and replace bone with a bone graft. But you can actually decide where you're going to put the implants, where you're going to put the central pin, and how you're going to reconstruct it and how much motion they're going to have before you even do any surgery. So it'll show you where you're going to pinch or bind and where bone spurs might be that you need to remove so you don't pinch and bind. This bottom right picture is a patient-specific guide. So after you get the CT scan and talk it over with the engineer that's working with you on the plan, they will mail you out a guide. And all it does is it gets that central pin where you want it first, and the central pin is right here. And then all the cuts can be made off of that. So the central pin is right here, and it just makes sure that you know exactly where the vault is here to get the best bone. And but that is helpful for a lot of cases. This is showing a patient of mine with just osteoarthritis, and there's an inferior big spur there, no joint space here. He's got typical wear on the socket. This is an axillary view, so we're looking up, and he's got bone-on-bone arthritis here, but also then there's a little kind of secondary divot here, which is most common where we see that the back part of the socket is the most damaged. This is another advance. It's just a stemless design that we use sometimes. This has got a little circular glenoid that I'm using now, and a central peg that is bony ingrown. And then it's got a highly porous coated piece that goes into the metaphysis, and then different size balls that snap onto that. So it's more bone conserving. It may be more conducive if there's a revision in the future. You can just remove this from the top and not have to worry about breaking down here or removing that. So in summary, from my point of view, shoulder replacement is a valuable tool to treat arthritis in the right patient. And if the rotator cuff is wimpy or certainly torn, a reverse shoulder replacement is the answer for that. If they have terrible motion and they're really old and maybe have lesser demands or significant destruction of the socket, a reverse shoulder replacement's the better option. And in an anatomic shoulder replacement, protect the subscapularis or it will fail. Thank you. I don't know if we have any questions yet, but I certainly am available to answer any questions for the next few minutes. And then I have to go back to the Grandview Vikings football game. So
I have a question. John asked, do you recommend end range passive over pressures for range of motion rehab?
end range passives over pressures. Oh, Jonathan, I honestly respect what you guys do, and I don't know half the stuff you do. When I was in residency, reading textbooks on rehab and things like that just drove me to tears. So I'm more of a kind of a carpenter type guy, and I don't know the answer to that. I'm sure you know better than I do. What I do is just kind of give the framework on what not to do, and then you guys know the science a lot better than I do about the rehab portion of it.
He also said pushing into resistance with stretching.
Oh, okay. I think that would be fine later on. You know, I'm pretty conservative though, and so I would say, you know, 6 to 8 weeks, I'd be just doing more of isometrics and not doing that. I would really be concerned about that until, especially in the muscles that I was talking about, until about 10 to 12 weeks. So.
Another question from Doug. What is the most common weightlifting exercise that contributes to long-term damage of the shoulder joint and or musculature?
I think, well, before CrossFit's one thing, you know, doing crazy stuff like the muscle ups and things like that, you know, that I think that sort of stuff's crazy. But I would say that probably like bench press, high weight bench press is really bad on the shoulder because you get more of that posterior translation of the humeral head on the socket. So heavy bench press, especially if you have a labral tear or something like that, is going to be very destructive. And I'd say muscle ups with for CrossFit. I think that doing things like deadlift and stuff are fine. I think doing curls and triceps and flies are usually fine, unless we're talking about gigantic weights. And I'd say pull-ups are fine too.
I'm getting a few more questions here for
Yeah.
you. Shelby said, I have a recent patient that wants to go back to using a chainsaw. What is your input on this?
I'd say wear those pants so you don't cut your legs off, you know, the metal pants or whatever. I think that'd be fine. I'd be much more apt to have them using a chainsaw than using an axe, even for like a small tree. So I think chainsaw would be fine. The vibration, I think, would be fine for that after, you know, probably 4 months or 6 months, preferably.
John had another question
Sure.
here too. Do you provide protocols after these surgeries or leave it up to the PT?
I do provide a protocol. It's pretty bare bones. It's what a lot of our docs use in our office, but it's mainly proscriptions instead of prescriptions, you know, things that I don't want to start until this landmark. So everything else I'm fine with.
Cheryl asked, how do you advise patients that use a walker prior? Can they use any support on a walker, balance support?
That's super tough. I don't have a good answer for that. Some of those people, if they're really relying on a walker, some of them might need skilled nursing. If we're talking about a reverse shoulder replacement, I might feel more comfortable, you know, with a week or something with skilled nursing, and then able to use a walker, and I've certainly had that happen before. With an anatomic shoulder replacement, I would be much more likely to hold firm on using a sling for at least 4 weeks and probably not even using a platform walker. So it's a really tough situation. I don't have a good answer for you on that.
Marie said, likewise, I have RTSA 6 weeks post-op who is talking about using a crossbow.
Crossbow, yes, I think I'd be okay with a crossbow, but not a longbow. So that'd be fine.
Okay. And Abby asked, what do you notice has been the most common factors leading to poor results / outcomes following these surgeries?
I would say the most common thing that I see with all the patients we see, my partners, patients of mine, for an anatomic shoulder replacement would be failure to either repair the subscapularis adequately or doing too much things too early and having the subscapularis fail. For reverses, they do pretty well. I think it's more of a patient factor for failure with the reverses. So people with unfortunately, it's going to be a lot of people who are sicker and older than the anatomic shoulder replacement. So you'll get more blood thinners, more diabetes. So you're more likely to get more complications of, hematoma, bleeding, dislocation, infection. So that's what I'd say for the reverses compared to the anatomics.
So Doug had asked about the most common weightlifting exercise that contributed to the damage, and we have another follow-up question to Doug's question from Brianna. Are there any other recommendations you have for us to protect our shoulder joint health? Preventive?
Unfortunately, it's a lot of genetics. I would say there's probably some role for nutrition, avoiding free radicals and everything that I enjoy, So eating well, eating healthy can do it. Avoiding injuries. So, and this is something you don't think about until you're in your, 30s and 40s, is maybe you shouldn't have been pitching that hard or doing those muscle ups with CrossFit. So typically normal use of a shoulder, if you have good genetics and don't have obesity or do a lot of other damaging things to your body, like a lot of alcohol and things like that, or free radicals, normally you won't wear out your shoulder from doing normal activities. But if you do have an injury, like you have a labral tear or you dislocate your shoulder in football when you're 18, then you have to be careful later on, because it's like the tire's on a little wonky and it's going to wear out faster than if it was on straight and true. So just like I tell my people with running, running doesn't cause arthritis in the knees, but if you had an ACL tear and they took out your meniscus when you're 18, then you're probably not supposed to be a half marathon runner, because you will get arthritis in the knee faster. So there's a lot of factors to it, but I don't think there's any supplements you can take or any type of a lifestyle thing you can do to guarantee you're not going to get it. A lot of the people I see are just, ladies who are 70 and never did much except gentle gardening, and now their shoulders are worn out because they have the genetics that were going to happen for that. So
I don't have any further questions right now, so. Oh, wait a minute, here, one just popped up. Abby said, have there been any pet peeves you have with therapy? What can we do as therapists to bridge the gaps with surgeons?
oh my gosh, I have to be very careful with this. I have a pet peeve, okay, but you guys can't change it, unfortunately. My pet peeve is that the therapy recertification forms and everything that you send are too long, and there's not enough important information in there. The important information is buried somewhere in there. It's not your fault. It's just the way that we have to get paid for, and have to have the, cover our CYA. And so I'll get 4 pages of blah, blah, blah that I already got before that has no meaning. And then there's your treatment plan, which is what I want to know. I want to know what their emotions like and what you're planning. And I have to look through that. So that's not your fault, but that's just the way that the computers are now in the electronic medical system and our government and our payers. And so that's the only pet peeve. I wish we could be on like texting terms with each other, and text about everything, but we really can't do that either. We just get overwhelmed with the numbers. So I think you guys do a fantastic job, and I wish we could be more, communicative and not rely on those paper forms back and forth to each other that really don't help either of us. So.
Jacqueline asked, how do you feel about shoulder replacement for seniors with dementia for treatment of pain, but who are probably poor candidates to participate effectively in therapy post-op?
Good question. I think they'd be a better candidate for a reverse shoulder replacement. There would be some risk for dislocation more than the general population, more risk for complication, but I don't think that they would be necessarily ruled out for that. But I think that they would be a better candidate for a reverse shoulder replacement because of the intrinsic stability of it. And the expectations would be lower. It'd be just, I want to not be in terrible pain all my life.
And then John asked, how often do you see a traumatic injury with the presence of chronic arthritis lead to a total shoulder replacement?
It's a lot of time. If somebody's coming in and they're a man and they're 45 and they've got arthritis, it's going to be from something like that. So typically, you know, some kind of sports injury or something like that is where we see it a lot. A heavily muscled guy, he's been, you know, he tore his posterior labrum as a college lineman and then kept doing weights and maybe manual labor and then ends up with bad arthritis in the 40s. It's a tough problem. Also, of course, if you have a fracture into the glenoid, so a scapular fracture that goes into the glenoid, that can cause arthritis if you get any kind of step off. And that's one of the few times we ever fix a glenoid or a scapular fractures if it's a displaced one into the glenoid, because we don't want that step off in the joint causing increased contact pressures. You can see it also in proximal humerus fractures in older people, typically not like a kid. If a kid breaks their proximal humerus, it's going to remodel well typically and not cause arthritis. But yeah, I do see that with a lot of sports injuries 20 years later. Like an ACL, you'll see their knee wears out 20 years later.
One more. Jenna said, we know not to expect great return of ER, but some patients have a wonderful return of strength motion here. Anything in particular that determines this? Just integrity of RC pre-op?
For external rotation, is that what she's? Yes. So if, and some of these, like we said, we're doing for people with intact rotator cuffs, just with other reasons. So if somebody has an intact infraspinatus, they're going to have a lot better external rotation. In my hands, most of the time I'm doing this, they've got a torn, a massive rotator cuff tear, which is more than 5 centimeters. So it's usually supraspinatus and infraspinatus. And then all I got is that little teres minor pulling into external rotation. And so, yes, you're exactly right. If they have better infraspinatus or even part of infraspinatus intact, then that will help their external rotation. It also can help. It's a balancing act. We usually we put the humerus component in a certain rotation. It's either neutral or retroversion, or we don't usually do anteversion, but neutral or retroversion. And depending on how we put it, you can get more external rotation, but it'll be at the detriment to less internal rotation. So we try and balance that. And if you do 2 reverses, sometimes you put one in 30 degrees of retroversion and one in neutral. So one arm can go external, one arm can, you know, get to the rear. So it can be some surgical factors, but also it can be the rotator cuff integrity back there.
We have the 1-minute warning until we're
Okay.
down here. So if any other burning questions that you guys have in the last few seconds here.
Thank you very much.
All right. Oh, one more. Here.
One more.
John said, if an anatomical replacement fails, do you always revise with reverse?
It's a great question. Almost always, yes. Almost 100% of the time, because once you get in there, you know, and you go through that subscapularis a couple times, it's not going to be very strong, very stable. If it's something simple, but then you might not, like maybe you put the wrong head in, it's loose or it's too big or something, then you might just change out the head. Or maybe the socket comes, if the socket comes loose, you're definitely going to reverse, but maybe if the stem comes loose and you put in a new stem, maybe you could do an anatomic, but almost always we go to a reverse. And then one other thing that I'd like to say about that is that with the anatomics that we use now, they're set up for reverse. So it's basically the stem and there's a middle piece, and that middle piece can be used either for a reverse or anatomic. So you can take off the head, take out that piece that you used for the anatomic and change it to a different piece that's ready for a reverse. So you don't have to go down and remove that whole stem typically, if that's not a problem. So that's been a big advance. Thank you very much.
Yeah.
Thank you.